The day after, the patients are being scanned because they are radioactive, so there's no need to do an extra injection, and you can get very nice scans. This is an example. This is a planar octave scan, the normal octave scan out of our project, and worldwide now available. You see here the first scan the day after the treatment of this patient. You see now over time that since this is a new compound, that this compound is much better than the old 20 years old octave scan. You see the tumors much better. But another phenomenon here is that after the different therapies, you see a decline in the uptake in these tumors. And if you see that, and the decline is more than 50%, then you can already say to the patient, because there are intervals of about 9 weeks between the cycles, you can already say to the patient, you will be a responder. You see here the octave scan after the last dose, huge difference, but by performing SPECT and CT, there were still small lesions. So this patient had a partial response, not a complete result, complete remission. Here another case, again, they post-treatment scans after 4 cycles. Here you see the CT at baseline, the CT 6 weeks after the forced treatment, and this one 3 months, and over time, fantastic tumor shrinkage in this patient. The same holds for this patient, with many, many lesions here in the liver, also shown here on the octave scan, and you see here the effect 1 year later. Another case was a rectal neuroendocrine tumor with hepatic metastases. This patient had only 1 kidney. No problem for this treatment. And you see over time also here a clear-cut tumor shrinkage. Another case, a gastrinoma with huge tumors, fantastic decline in the tumor markers and anti-tumor effect. And here again, a patient with huge metastases in the liver. And then the 2 last cases are important. You can see that also already on the scan, on the size of the scan. Here you see 1 tumor and here the effect. And that is indicated here that the patient lost 15 kilograms body weight, and after the first treatment, in 8 months, the patient regained 14 kilograms, indicating that the patient is doing much, much better. And in this case, it was a combination of treatment. In the beginning, like all our patients, it was an inoperable patient with tumor, again in the head now of the pancreas. The patient was treated, there was a tumor shrinkage. 3 months after this CT scan, there was an identical finding of a small lesion, and then at that moment the surgeon decided to do an operation, and that is indicated here, a successful Whipple procedure plus reconstruction of the part of vein, resection of the edges and lymph nodes, tumor-free, discharge in mid-2005. Until now the patient is tumor-free, and we have now about 10 cases of a complete cure. So we can conclude on more than 300 patients that PRT with lutate and GAPNet shows anti-tumor effects not shown before chemotherapy or other treatment modalities. What about quality of life and survival after this treatment? This is a rather complicated slide, but it's not really the case. You see here the data of our first 50 Dutch patients treated with the lutate. And for instance, take this bar, 43 out of 50 had fatigue and 29 improved after the lutate. Diarrhea was present in 22 cases and 16 improved. And then to note, this indicated here, that already 50% of our cases were using cold octreotide, and that is a very good drug against those symptoms. And now, survival, that are new data of this year. We are lacking a control group, so we have to go back to historical controls, and that is normal with this orphan disease. It is a busy slide, but in fact it is also here simple. You see here yellow bars indicating the results of overall survival in these reports. And in the reports, different subgroups of patients have been published. So what we did is we selected similar groups of patients from out of our 310 cases and calculated the overall survival for those lutate-treated patients. And you see in all cases that the red bars are higher than the yellow bars, indicating that the survival in this comparison is better for lutate. And then the take-home message is that this difference is the survival benefit is 40 to 72 months from the day of initial diagnosis. That is a big, big difference for patients who are inoperable. I would like to conclude with one case to show how important quality of life is. That is this poor boy, 15 years old, with a paraganglioma, not a GAP-NET tumor, but it is a neuroendocrine tumor well known to express somatostatin receptors. But also, it can be treated, these tumors, with MIBG. This boy was treated with one curie MIBG and with chemotherapy. And at the end, the tumors were not taking up any MIBG anymore, and this treatment modality was impossible in this case. And according to the oncologist, his survival is less than 1 year. So he was referred to Bad Berka in Germany for treatment. You see here his somatostatin scan, 50 minutes, 1 day, 6 days after injection, and you see those many, many tumors. All the black dots indicate the presence of metastases. Here also in the skull, this is the standard, it's outside the body. And here is a big tumor in the adrenal. So this boy, a wheelchair boy, after high dose of MIBG treatment and chemotherapy, was treated in '97 with this new treatment modality in Germany. And you see the difference. In the year 2000, when he is 20 years old, saying, I'm feeling better. But here you see his difference in the years, clearly visible, but also stated here. I can walk again. The year later, I can go jogging again. And finally, as is shown here, he is playing football with his father. And that is important that in this case, nice example of a patient, a young patient, with very extended disease, that after PRT with a labeled somatostatin analog, his quality of life was highly improved and his lifespan also. So the conclusion for the GAP-NET is that PRT is a fascinating new tool, at least for patients with inoperable disease, with a high tumor response rate, limited side effects. I had no time to show you the side effects, but it is stated here in only 1% we see serious adverse events. One interesting point is that there are clues to increase the receptor density on the tumors by epigenetic modulation, that is methylation and deacetylation. And finally, Professor Mecke in Basel has now done research that possibly antagonists of these analogs are better for this purpose. And my last slide shows you the feasibility that indeed 800 millicurie is not the top. We can go higher. We have shown that now in more than 30 patients. You see here the effect after 4 doses. That is the tumor marker going down. You see here a nice improvement in this case on the CT, as well as the post-treatment scans. Here there is a relapse shown here on the CT scan. Finally, the patient here decided indeed to get additional treatments. He got 2 extra cycles, and here in February, you see the decline in chromogranin and improvement in the CT. And the good point is that with a follow-up of about 1 year in those cases, the side effects also are very minor if you give patients a 5th and a 6th dose. So this is the end of my talk, that I'm showing you a proof of principle with the somatostatin receptor in a group of patients of whom the incidence is very low.